So today we are going to show the steps involved in the basic proton planning, and myself, Dr. Naufal, and Nagarjun, he's going to start.
Hello. Hello everyone. Myself, Dr. Nagarjuna. So I think the last in the last 2 hours you had a tour, facility tour, and immobilization procedure, and everything in detail. So once the CT simulation is done, all the images will be exported to our treatment planning system. We have Ray Station as the treatment planning system, and we import all the images into our treatment planning system. And after importing, our work is delineation of the targets. So next question comes is there any difference in the delineation of the targets compared to what we contour in IMRT? Hello. Regarding the delineation, next question is like, is there any difference between the contouring in between what we contour in the photon in IMRT and proton? So the target delineation, like gross tumor volume and till the CTV, that is a clinical target volume, there is no difference between the photons and what we contour with the protons. But we have to use the adjunct radiological imaging like PET-CT and MRI for the delineation in the proton, because each and every OAR and also each and every structure is very important, because proton, actually there will be dose perturbation if there is any change in the beam path. So after clinical target volume, we give dose prescription. Dose prescription, we follow the Quantec guidelines. Yes, the Quantec guidelines, if you see at some points, it will be difficult to achieve in IMRT plan also, like with photons. Here with protons, we will be easily be achievable these Quantec constraints. So we actually are little aspirational and give very much tight constraints what the Quantec has been advised. And once the dose prescription is given, we we tell our physicists what is our hard constraints, what are our priorities, and what clinical effect we have to reduce it. And regarding the PTV, I don't want to stress more now. Once at the end of the session, I will tell you why the PTV should be given or not. And we routinely give PTV just for the reporting purposes, as ICRU defined. Now, Nofel will tell us the basic steps of proton planning. Please, Nofel.
Um, Before going into the proton planning, uh, so before going to the proton planning, it's important to know the basic physics, because the physics behind the planning is important. What basic physics? Yeah, I think so.
Okay, so sorry for the interruption. So, as Dr. Nag mentioned, the complete physics is changing. So, you should understand what are the three basic interactions. So, if you understand these basic interactions, you can do the planning. So, there are three basic interactions going to happen when a proton interact with the medium. One is it is going to inelastic collision with the nuclei. That leads to the production of neutron. Here you can see our bunker, you might have seen now, because our main idea is to control the neutrons. So it is basically it is going to be the neutron interactions that will be controlled. This interaction is very important. The second interaction is very important. It is called inelastic collision with electron. This leads to the dose deposition. So this is going to happen. The dose, it is going to interact with the electrons, and then it leads to the dose. Third interaction, it's called multiple Coulomb scattering. You always might have heard about the pencil beam scanning. So pencil beam, its pencil is defined in the air at 3 mm spot. The moment it enters into the medium, it is going to happen. What is going to happen? It's going to happen the multiple Coulomb scattering. The spot size is going to it's increase. So there are these three things is going. It's going to play in your planning. You're going to see now. So this is called how this Bragg peak, why there is no exit dose. This is the equation. This is the Blatherbock equations. This is going to explain everything. So you can see this is the stopping power. It depends on, forget about all other equation, all other components. Just concentrate on these two parameters. One is called the Z, atomic number, and the B, velocity. So the stopping power, it's inversely proportional to the square of the velocity. So what is going to happen when a proton enter? It's slowly reduce the velocity. Then say at that time the stopping power increases and it deposited all the doses. And it depends on the atomic number. So these two factors is going to play major role. Some other factors, I values, it's there. So these two factors you can see how the peak is formed. This is the stopping power. It's increasing at the end of the peak. This is the fluence. If you multiply by these two factors, it produces Bragg peak. So there is no exit dose beyond this, so you can save your critical structures. So that's the physics. This is the physics. See, this is our usual PDD. If any critical structure is there, there is an exit dose. There is a lower dose, it's going to be there. Here, you can exactly point out the corresponding energy. This is called the range. Range varies with the energy. So we are having 230 MeV to 70 MeV. So depending upon the depth, we have to choose the energy, and that energy has to deposit the maximum dose here. There is no dose beyond this point. Then question comes in your mind, then one single spot is enough to treat a tumor? The answer is no. Because the single spot is not enough, because if you put two spots, it's not going to cover. I just created one hypothetical target, just to want to show. So this is not enough. You required multiple spots to cover this. So we have range of energies. Okay, it starts from 70 MeV to 230 MeV. So 230 MeV and 70 MeV. 70 MeV, it's called range, where the maximum deposition is the depth at which the maximum deposition is going to happen. Then you combine all this energy, it will produce a SOBP. It's called spread out Bragg peak. So this is going to happen.
And Nofal, yes, we understood that the beam path is crucial in this. So what pre-planning checks you take into consideration, and why?
Thank you, Nag. That's a very important question, because as far as the planning concerned, now you understood what is SOBP. So one of the important point, keep in your mind that we know proton is going to stop, but same time, we don't know where the proton is going to stop. That is called uncertainty involved. So there are quite a lot uncertainties is going to come into play. So when we get any, what you call this, the CT scan with the prescriptions and all the structures, we are going to do a pre-planning checks. So what it involves, I'll just tell you. First, you will check the positions, and we'll check, therefore we have done it during the time of simulations itself, and checks any artifact in the mold care itself. You might have seen the mold care now. Okay, sometimes what is going to happen, it's going to create some artifact inside. This is going to perturb your beam if you pass through this, And any dental metals or any beam hardening metals, it's going to perturb. Then you can ask why this is, we are not bothered about this much in the photon. Why you are not that much bothered in proton? So the answer is here. The answer is, this is the PDD. If you put any material, okay, you put a 3 centimeter dense material, it is not going to change your energy. Only the fluence is going to change. It leads to an attenuation. It's going to decay in terms of exponentially. But if you put it here, this is going to degrade, it's reduce your energy with the same fluence. That leads to completely missing of the target. So here it is more crucial. You have to do all the pre-planning checks, okay, before you start the planning. So it varies with the site to site, what things you'll have to check it. I'll just explain. When you have a simple brain cases, it may be some shunt will be there, some screws will be there. So we always disturb our clinicians because we'll ask what kind of material, some dental implant will be there. We'll ask what kind of material. We will always insist to get the material because we require to put it in our planning system to get a correct stopping power and the correct dose calculation. Sometimes patient may come up with all kinds of materials like ceramic materials or zirconiums, all kinds of materials. Sometimes we come across these types of screws. So in our center, we adopted a new methodology. So we have already explained, I just tell you again, because this is more and more very, very important, because if you don't do this assignment, you are going to completely make your dose calculations inaccurate. So what we'll do, we'll take the MVCT scan, because always you can see there is an artifact behind in the scan. So we'll take an MVCT to get the geometrical uncertainty. To avoid the geometrical uncertainty, we will fuse it, and we will assign the correct material, and we will assign the tissue, because in order to avoid, if the tissue is there, we'll assign, in order to come across the artifact, we will assign the correct tissue values. The dental material we will find out. So several things will sometimes block it. So it varies with patient to patient. So let's go to the case now, because we are going to show you a simple case. Okay, so over to Dr. Nag is going to tell you the case.
So I can understand each and every beam path material is important. So it helps, how it helps in selection of the beam angle. I think you will be telling in the next few
yes.
things.
So now you understood. It's now you can see here, because I was telling we have to. So there are certain things like first. This is our, whenever we receive a planning CT, we have already done our pre-evaluations. When you're okay with the pre-evaluations, you have to assign the density file. This is also very important, because we have done a thorough investigation on this. We have created two calibration file. This is convert Hansfield unit into mass density. Then from the mass density, there is a it's a pre-scripted version inside the system. It will convert it into the stopping power. So we have two imaging, what do you call this, two sets of HU files are the one is corresponds to the our head, and another corresponds to pelvis. So depending upon the situations, we'll use this one. Okay. So let me log in.
So he is going to show one, it's a case of that 11-year kid with recurrent craniopharyngioma post-surgery. Till post-surgery, there is small residual in cella and suprasellar region. We have given the routine target contouring, the residual contouring, and also margin of involving the cella, suprasellar, and margin of 1 centimeter CTV, and with a dose prescription of 54 gray in 30 fractions. And he will be showing us how the beam arrangement he placed. So many of times these craniopharyngioma patients will be coming up with different material like shunt. They come with us with shunt, and the shunt is that they have to take into the criteria of the shunt material and everything. So we'll be in touch with the neurosurgeons to immediately tell us the shunt material, and they will be discussing with their vendors, and we will be struggling so much times to get the shunt material. So, but now since the last 2 years, we got the materials, and even our physicists are also happy with the things what they got now. And now you can tell me the selection of the beam angle, how you.
So before going to the beam, I just want to point out this is also very important. It's going to be different from your photon. Because here we have to tackle this Molcare. Even though the attenuation is less, we always put the Molcare. This is called external. You'll call it body in your clinic. We'll call it as external. And then here you can see we bother about this BBs also, because if this is not going to be there during the time of treatment, so how to avoid it? Either you take it from the external, or you assign this as a air. So we bother this one also. So we take care all the beam hardening material in the path. Okay, so the question about the beam angle selection. So the Proton, there are several steps involved in the Proton planning. So I said already the pre-planning checks. We'll do a thorough investigation about the pre-planning checks. We bother about all the artifacts, everything we have already taken care of. Then, what is the steps of planning? I'll just show you the steps of planning. So, you can classify the steps of planning into 4. One is called delineation of the structures. This is called physics structures. Once they handed over the structures to us, we have to create several optimization structures, which is different from photon. And then beam geometry, optimization approach. Everything is different. So I'm going to explain these 3 things, nothing else. The 4th thing is my colleagues is going to explain. This is also very important, the evaluation. So delineation, it's different because here you will call it a spot, the Proton, the spot assigning structures. So you should define where the spot has to place. This varies from site to site. I'll just show you. And the blocking structures, sometimes you don't want your Proton to put the unnecessary spot on some normal tissues. Then dose control structures. Then beams, optimization. So this is the first one. I think Dr. Nag want to ask some question.
No. I just want to tell delineation of optimized structures, how it is different from our targets. Can you elaborate it?
Yes, I'll tell you. So this is, I just want to show you, because this is a CSI case, but it's different. Here, you want to place, because you are going to place multiple beams. Like we usually put 2 posterior beams and 1 posterior beam here, and you have to get at junctions. Okay, so you have to place the brain beam has to place the spot exactly to this point. So you will be creating structures, and you will be assigning in the planning system. This is, we'll call it as spot assigning structures. It varies because this is a CSI case. Some cases we won't create it also. Some cases we'll create it. It depends on the site to site and the techniques we are going to adopt. And sometimes we'll use a spot blocking. We don't want any spot to place at this point. So spot blocking structures. So we have done a thorough investigations in the CSI. You can read this paper, okay, to know how we are creating these plans. I'll just go to delineation of the structures in the head and neck because it's completely different. Here you can see these are the 2 opti structures, because we want to place your anterior beams or right anterior oblique. The right side beam has to play the spot here, so that you will completely utilize the exit dose or the end range effect. Okay, so you can see 2 structures will create. Apart from this, we have to create several excluded volume structures to control the dose spillage. So this is called the delineation of the opti structures. And I'll just show you in that case what the opti structure we created in the case.
Please feel free to ask any questions at any point of time.
So this is a very simple case. So I don't want to make the complicated cases. So it's a very simple cases we have done it. So you can see we created the ring so to control the dose spillage. Okay, this is a very simple case. So and we created the external. We placed we checked everything. We assigned the correct density files. So after density files, the next step is going to be the beam geometry. This is also going to play a major role in the selection of when we do the planning. I think any question you can ask in between, you can interrupt us. Okay? Yes.
Specifically this MVCT, what you do, I mean, you decide like what kind of material you will do or?
Yeah. So that's a good question because I just show you, because always if we'll get a metal, it's going to be, the artifact will be there, okay? So we observe that even though if you use any, what you call the correct window level, the geometrical uncertainty is going to be there, because suppose there is a 5 mm material is there, and you take a scan of CT scan and an MV scan, you can see exactly the 5 mm scan is going to be, the geometry is going to be higher. So in order to get a correct geometry, we'll use an MVCT, we'll fuse it, and then we will get a correct geometry of that material, because it's sometimes very difficult to visualize in scans.
Naufal, I think the question is, when do you choose to do MVCT?
No.
All kinds of material or any specific material?
All kinds of materials. All kinds.
That's all.
Yeah.
That's the
You said, no?
Yes.
That you literally contour that.
Yes, we will do it. We'll do it. Yeah, it's a good question. Sometimes it's very difficult to get the material from clinicians, you know. So in that case, if you don't know, most of the times we will try to block the materials. Okay, there is a separate technique is there. It's called blocking. Okay, so we'll block it. We should not pass any materials through that. Okay, and that's what we are going to do. Okay.
Mostly we will be they are saying that they will be avoiding beam entry through that. That was Loki's telling.
beam avoidance
Yes.
to that material.
Yeah,
Wherever possible.
yeah, I will add something onto this. Of course, I think in the very beginning we struggle a lot because I think we have to get all the details of this particular material, and sometimes we get it, sometimes we don't get it. But at least what we try to do is that we try to get the brochures, and we go through their website, and we extract all the informations, and we started building up our own library, because sometimes we get it, sometimes we don't get it. So we have already built up a library, and by collecting all these informations, and whenever we have this kind of situations, we try to extract all those informations from the library. And the beam angle, again, what of course I think that will be discussed by Naufal again, and that depends upon case to case, and we have done separate investigations for different clinical sites. And say, for example, for head and neck, if we have a mandible implant, then from which angle the beam has to be directed, and what are the perturbations. So all those investigations was done separately, and it was discussed in one of our presentations on the first day itself.
Okay.
So it's case to case different.
Okay. Thank you. So after the delineations, we'll do the beams. So in this case, we have done a thorough investigations. What beam we have to choose? Okay. How we are going to put the beam angles. So because beam is also very important, I'll just show you. So here we have to avoid the end material, and it should not end range on the targets also, and it should not end range on the brainstem. And this is also very important. So with these two beams, you can get the distributions. You can use this beam or this beam. So which beam you will prefer? We'll prefer this beam because it's not end-ranging on the brainstem. So it's because we want to avoid the RBE. So I'm not going to talk in detail about that. Okay. So there are several other things you'll have to consider, like beam robustness, Okay, the what is robustness? I'll just tell you during the time of optimization. So we always, when we started, we have done a thorough literature survey. Suppose there is a centrally located tumor is there, so what type of this thing is required? And then we have done a thorough, we have put a different kinds of beams and we investigated with respect to VMAT plans, and then we finally come across this beam arrangement. So in this patient, I'll just tell you, we put a 2 lateral oblique and one vertex beam, okay, to get the beams. So we have put 2 lateral, the 270 and 90-degree beam with a vertex beam. So after beam selection, the next is going to be the optimization. So he has some doubt.
Can you show the...
Is there any question regarding beam selection? Yes.
Yes, yeah,
Yes.
exactly.
Sorry, you were
Can you
asking.
show me the doses actually?
Beam selection.
Okay,
she's
so
asking
as I
you.
said, it's varies with patient to patient. So this centrally located tumors, we will always use the 2. Always remember in your mind that always reduce the, you are not going to put a 7 beams or 8 beams or 9 beams as you seen in IMRT. Here you may go up to maximum 4 beams or 5 beams. 4 beams we usually use in the case of head and necks. We'll put an X beam arrangement. So you yesterday might have seen our talks. X beam arrangement. So we come up with the class solutions. And the central located tumors, we'll put a 3 beams. So it's varies. A breast, we'll put a 2 beams, 2 anterior oblique beams. We will show all the clinical cases. When we'll show the clinical cases, we'll discuss. So in this case, we'll put the 2 oblique beams. So that is also chosen different conditions. I showed you the robustness, because robustness, I'll just explain you what is robustness. And it should not put up, because if there is any movement is there, it should not put the spot on the chasms. So all these things we'll take.
Okay, Naufal, before going to the robustness, one more. Okay, you have shown me this centralized location tumor. And in the previous slide, you showed that minimum proton energy we used is 70 MeV.
Yes.
So the depth is like 4 centimeter.
Yeah.
So what is the, means like what peripheral tumors, how you tackle?
Okay. So that's a good question.
Because how we typically choose is the shortest beam path. Should not end range in an OAR. So there are certain rules of beam selection. So that is what Dr. Naufal is trying to emphasize, that there are basic rules of beam selection. And we have now, based on literature review and our own experience, we have come out with some class solutions. So if the tumor is in location is say a cellular, supracellular location, we choose these beams. If it is one-sided lateralized, we choose these beams. If it is esophagus, we choose one. If it's prostate, we are choosing one. So there are certain class solutions. So go ahead.
Okay, so as Nag pointed out, if we have 2 energies, like maximum is 270 and minimum is 70. 70 is going to put the dose, the maximum dose deposition is 4 centimeter. If the tumor is, it's superficial, then what we are going to do? So you might have seen, there is it's called, we require the range shifters to pull back our range. You might have seen the machine now. This is called the range shifters. So this is the plan without range shifters. So you are not getting any dose here. Suppose the target comes here, you have to push back here. So you will get a nice distribution here. But there are certain things you have to check it during the time of planning, especially the range shifter positions. So we will try to maintain the shift positions as close as possible. We'll always keep 5 centimeters from the patient, but that is also very challenging. So all the time you have to go into the machine and check it whether it is colliding with the system. Now from our experience now we know that the range shifter is not colliding. So I'll just show you one example of the range shifters.
So it is like pulling the dose towards periphery. So it's like bolus in photons.
Yeah, you can say like that. So here you can see this is the nominal plan. We'll call it as nominal plan. We keep our range shifter positions at 5 centimeter depth. If we keep our range shifter, if somebody is it's not able to keep it, it's very far, or it's wrongly put, what is going to happen? Here you can see you are not going to see much difference in the higher isotope lines. Okay, if you see the other lines, you can see the difference Okay, here, this is the difference you are going to get. The brainstem is going to get higher dose. This dotted line represents the range shifter position not in the correct place. Range shifter is going to away from the target. So this is also important. So after beam, you keep the range shifter in the correct positions. Okay, the next is you have to optimize. Okay, so I think you can ask any questions you have, okay, about the range
Are you
shifter
guys
position.
understood about range shifter? Yes, great.
Okay.
Because the smallest, the lowest beam energy is 70 MeV. 70 MeV has a Bragg peak at 4 centimeters. So if we want to treat superficial targets, we need to pull back the range. So that is why range shifter. And what Dr. Naufal also said is the air gap will significantly change. Okay, please. Nothing like that.
It's actually, it is nothing like that. You can see, it is, you have to utilize the proton, correct? If you pass a proton from all the sides, you're going to lose the advantage. So minimize your beams. Actually, that doesn't mean that you put one beam. There are lots of uncertainties involved. I'll explain in detail. So minimum 2 to 3 beams, it's okay to create a plan, good distributions. In head and necks, we required 4. That is a special technique, we'll call it as X technique, okay? And in CSI, it's 2 posterior beams are okay. So minimize your number of beams. And also the beam selection is very, very, very important, because you should not pass your metals, and it should not end range, okay? So all these things are important. Exactly. Yeah.
Distal part of the beam will have uncertainty about penumbra as well as RBE, theoretically, which
Correct.
is discussed about protons. So by adding more number of beams, can we take care of that?
Exactly. Yeah, exactly. So that's what.
Correct. You understood it well.
So that's what you should not put end range, and you use the multiple beams in order to
mitigate that
mitigate the uncertainties. That's the idea. So next is comes to the optimization. So what optimization you are going to use? Okay. So whether it is what approach you required, because it's going to be different from the photon. So optimization, if you consider why the optimization is important, I just show you something important, because
Naufal, one question. So
Yeah.
one basic. Okay, we are RB Proton RB is 1.1.
Yeah.
We give prescription like 50.4 gray equivalent in 30 fractions. So whether this 1.1 is taken into our, how do you take this? It is taken into our systems already, or that Proton gray equivalent? Can you tell to the audience?
Yeah, you say 7-degree RBE because we already taken into account this, it's in the system itself. So you prescribed in terms of 7-degree RBE. So RBE is 1.1 is already multiplied the systems, and it's already taken into account. So what is the optimization approach it is going to be? Because it's,
Just wanted to know, would you
Yeah.
treat skin tumors with new protons? And if yes, would you use bolus?
Per se, skin tumors we wouldn't treat only with protons. I mean, if we could be treating tumors which are extending to the skin, but only skin tumors, I think we would treat with electrons. Why not electrons? No need for protons. So, but if there is a head neck tumor extending up to the skin, or a chordoma extending up to the skin, those are patients which we can treat with protons. So, skin extension is not a contraindication for protons. We can treat it. No need. That's a range shifter.
That's it.
yeah. So here, I'll just tell you one thing, because you always put the PTV in your, yeah.
See, in these head and neck tumors, or in base of skull tumors, where you have an air gap with respect to the sinuses, how do you account for that? Or even in lung tumors, where there is a lot of air gap.
No. You can.
So the air gap is between the body, the skin, and the range shifter.
So within
Inside
the
air gap is no
it's
issue.
not-
If it is,
no
if it remains stable every day.
For the example, the sinuses, you're not going to.
No. So there is that is a separate discussion altogether.
Okay.
The sinus fills on a daily basis and it comes down, then it becomes a problem. We have ways to optimize that also. Naufal, you can explain a little bit.
See, I just avoid your confusion. The air gap means air gap between the range shifter and the patient body. So that's air gap means. And your question about the sinus filling, of course, the sinus is going to impact, because when we do a plan with the open sinus, and it's filled, it's going to change physics because the proton is going to, the range is going to different. How we are going to tackle, we already have come up with a solution for that, okay? So that is required in detail discussions because we always incorporate these variations in our planning systems, okay? I'll just tell you
So
one.
we do a quality assurance CT every few days. We do CBCT every day. We see the sinus filling, whether it's filled or unfilled, and does it needs any change or adaptation based on the sinus filling. That we do separately. I think that is a very lengthy discussion. We'll come to that later. Currently, we'll stick to the basic steps of planning.
Okay.
Is that receptor made up of?
It's called Lexan. It's
What
Lexan.
exactly it is?
It is PMMA. It's some sort of PMMA material. Okay. Yeah. So here this is very important because I just want to tell you only the basics, okay? Because you put a PTV, correct, in your system, because in your planning. But this we will create a static dose cloud around the PTV. That's the usual concept we usually use it. But we usually perturbation means if you'll apply a setup uncertainty because to your isocenter, that's called setup actually perturbation. So perturb and see actually whether this distribution is hold or not. You can see this perturbation is going to happen inside the target also. So that means that if you put a margin around the target, it is not enough because if the endodose is going to happen inside the target, it's not enough. So you require your optimization approach is going to change. So in Proton, the optimization approach is different because this is the normal setup. If the shift, it is going to completely miss. The density change, it will underdose or overdose. If the motion, this is going to change. So how to tackle all these things in your planning, so that is very important, how we are going to do. So the approach which we'll call it as robust optimization, that is always we'll do it in our all the planning. So what you mean by robust optimization? So robust optimization means you know that the setup uncertainty, it's going to happen, the density change, which is called, it's going to perturb your range, and the anatomical changes. You combined all these scenarios, okay, you incorporate in your inverse planning approach, that is called the robust optimization approach. There is a very good paper, it is called the Fredrickson from Ray Station. You can read this paper, it's a very good paper. There is a certain set of equations. Usually in your cost function, we'll call it as cost function, you are going to minimize only the dose to the target and the OAS. Here there is one more function we added, okay, in order to tackle the setup and range uncertainties and try to minimize. So it is called minimax approach, okay. So if you want to know about, you can read that Fredrickson paper in detail. So this is already incorporated in the Ray Station planning system, okay. And we can put how much range uncertainty, setup uncertainty you want. Usually we'll use the brain cases, we'll put a 3 mm. So instead of putting the PTV, we always optimize in terms of CTV by putting these values. This is called the robust optimization, both tackle into account the setup uncertainty and the range uncertainties. So then we'll do the optimization, and okay, then we have another part which is called the evaluation. So that is also going to discuss in detail. So I just want to point out this is also important. So we have already published some sort of papers actually in order to stress in this, not only for the proton, it's important for the photon also. When we put the IMRT with the robust optimization, you can see this is the band of DVH we usually check it. This is less. So the robust optimization, that is the technique we are going to use in your planning. And then next question comes up, what type of robust optimization, how much the value you are going to use it, whether it is 3 mm, 3.5, so what is the value? So it's also varies with the site to site. There is a very good publications are available. So if you increase it, it's going to increase your NTCP. So you have to come up with a balance between the range and setup. So if you go to 7 mm, your NTCP, normal tissue complication, is going to increase. So we usually put a 3 mm, 3% uncertainties. You cannot reduce also. Okay, so this is a very good paper. You can read this paper. So based on all the investigation studies, we usually put 3 mm, 3.5% range uncertainties. Okay, so that is optimization approach. So robust optimization is required when you do the planning. Okay, so you have any question you can ask about the robust optimization.
So robustness is simply to mitigate the translational errors plus the range uncertainties.
Exactly.
The range is what is said is 3.5% based on the literature. So where in normal photons we don't see this range uncertainty. So here we include that and the robustness they do. And while doing the robustness, the translational errors, what they incorporate, it depends upon the site wise. Like CNS is 3 mm, and then the thoracoabdominal may range up to 5 mm. But the range uncertainties our physicists are using is 3.5%.
Yeah, that's what. So that is very important. So there is an approach. Either you can do a CTU base. You don't put the PTV margins. You can purely put a full optimization. You put a CTV and then you optimize it. Otherwise, you combine the PTV and CTV optimizations.
So you have set the optimization procedure.
Yeah.
Any questions? Or otherwise, we can ask Nofal for what are the different types of optimization, how it is important while planning.
Okay. So when you go to the planning, you are going to heard these two terms. One is called SFO, one is called MFO. What's the difference between SFO and MFO? So in a simple term, this is called a single field optimized and this is called a multi-field optimized. Why it is different? I'll just explain. Okay, so just look at our case. So this is a centrally located tumors. We have used three beams, and our prescription is 54. And we have put the beams and we have done the optimizations. Now we got the distribution. Okay. So what approach, SFO or MFO? So you have to give a 54 gray to the target. If you give this 54 gray equally from 3 beams, that means 18 gray, that is called SFO, that's all. So you are going to give equal contributions from each beam. Okay, so that's called SFO. So I'll just show you. See, here you can see this is a contribution from one beam. Okay, it is putting 18 gray in all the parts. Second beam, it's putting from all the parts. Third beam, it's putting all the parts. This is called SFO. So people always say that when we started also, when we went for the training, the people say this is going to be more robust because it is equally coming from each beams. Even there is any perturbations, it's going to tackle from other beams. So we also started using this SFO in the initial planning approaches. Then we improved by day. Then some situations, we have to use MFO also.
Means like in SFO, the single beam looks over the whole target and the single beam that is contributing the dose to the target is homogeneous over the target, all the target.
Yeah. So then what is MFO? MFO it's something like each intensity is different. It's completely purely the intensity it's defined by the system. You don't have any control. You can do some control, and it's something like if you want to treat this patient, it's contributing from the intensity is going to differ from different patient. I mean, it's different beams, so that you can spare the critical structures. Especially when in all the head and neck cases, we have to use MFOs. With MFO, I already said the robust optimization approach. So this small type of cases like what we have seen, this case, we have used with the SFO, and this is MFO. There is much difference. You will get almost all kind of what you call the distributions almost same. But if you go to some other cases like the crudomas, okay.
So simply put, if SFO is very good, it is satisfying all the constraints, would you try MFO or still SFO is the good?
I think I'll try with only SFOs because it's going to be more robust and there is uncertainty is going to be less.
Are there any questions related to SFO now? Yes. How to choose between the two? So,
How do you choose?
Okay.
You have to do both?
No. See,
one more question. One more question.
We had a discussion about that shunt material, etc. initially.
Yes.
Yeah.
So you have a lesion which is right in front of the brainstem. Brainstem's density is different. The lesion itself, the cyst part of it is different. The solid part of it is different. There is your shunt in front of it. So many things dynamically changing over time in weeks, and so how do you account for this with SFO or MFO or whatever it is?
So that is precisely the reason why SFO is better.
Yeah, exactly. So, see, thing is that even there is a hardening material. I already said you have to tackle with the first step itself. And we have, if the shunt changes, we usually check with the QACT. If any changes, you have to do the replanning. So all this, if there is a, so if there is an uncertainty, not only the shunt, the setup uncertainty is there, range uncertainty is going to happen. So SFO is going to be the, in practically you can say that it's going to be more robust. But over a period of time, you will realize that if we apply a correct setup and range uncertainty during the time of planning, you can make it that also robust. So that's what.
I think we can
Yeah.
at a small point on these questions.
Yeah.
Whatever the heterogeneity, dynamic heterogeneity you have mentioned about, that will be taken care by our calibration graph. I think we have shown in the very beginning that we have a mass density to Hornsby unit calibration graph, which in turn is converted into the stopping power ratio. That will take care of that. But there are some foreign materials like the shunt and some implant and all those where it doesn't fit into that calibration graph. Because this very high jet or very high atomic number material, they don't fit into this particular calibration graph because there is a lots of uncertainty for that. So that's why we have to identify all those foreign materials individually, very precisely, and we have to assign the appropriate mass density for that. And that will take care of the perturbations of the ranges during the time of treatment planning. Okay, so even in that case situations also, sometimes what we see is that I think since the IMPT, what he is demonstrating is so heterogeneous, sometimes I think if there is a slight deviations of that particular material itself during the time of treatment, so it may perturb or it may shift the entire dose distribution. So that's why SFO is more robust in those kind of clinical situations compared to MFO. But having said that, this kind of complexity arises, I think this kind of things happen when you have a very complex target. And our another goal is also to spare the critical organ. So even if we have all those situations, sometimes or many times we have to use the MFO because we have to get our clinical goal.
Exactly.
And there is ways to mitigate. So that is, I think probably when we discuss about the class solutions and all those things will come up again.
Adding to that, we have stringent QA protocol during treatment. So every week we will be doing QA-CT and we will overlaying the day one planning CT scan. And if any dose perturbation is there, then we will do adapting. Because in these tumors, we see regression of the cyst we have seen.
So here I just want to point out one. This is made up of SFO plan and it's MFO plan. So if you see here, you can see I want to curve the beam. Okay, if you want to curve the beam, it's very difficult because it's going to contribute from equally. So it's very difficult to curve the beams and get the brainstem the mean dose. So to reduce the mean dose here, most of the time we use the MFO technique. So in the type of complicated head and necks, we prefer to use MFO, and you have to tackle this any perturbation. So we have a clear evaluation there. It's going to discuss in detail now how we evaluate it, how we evaluate our after planning. Robust evaluation is going to come. Then so that is we have to whether this is not enough, whether this if any changes that we are going to perturb it and see this changes anything is going to happen. Okay, we have a bunches of DVH. We are going to check it. And then we will evaluate in the MFO plans also. So once you're done with the plan, you understood actually after optimization, the approaches, whether it is SFO or EMFO. After question in mind, what is your final calculation? So whether it is Monte Carlo or pencil beam, okay? So why in our cases, almost all patients, I can say all patients, we are using the Monte Carlo algorithm. Why it is so important? I'll just want to share, okay? Uh, I'll just want to share why the algorithm is so important. If you see, this is a paper from Italy. It's from Venisoto. They have calculated. This is the pencil beam calculated. They have done measurements. Okay, this is the calculated in pencil beam. This is calculated in Monte Carlo. So you can see the difference actually. Pencil beam is going to overestimate the dose by 25%, especially the high inhomogeneous mediums, and underestimate the dose. So we commissioned in 2018, when we started, we commissioned the Monte Carlo in order to avoid all these things. So you can see this difference, the pencil beam calculated versus Monte Carlo. So we always use the Monte Carlo algorithms, and for all our cases now, especially any inhomogeneous things are in there. And after the optimization and the calculations, then you have to check your brag peaks, where it's ending and how it is ending. So you should know the spots, where the spot is located. These are the spots, okay, in the systems. And then you check whether the spot is not placed, which is very far from the targets, and you have to avoid all those things. Okay, so these are the basic planning steps. So we covered the basic, the checks.
Now, let's take a pause and let's see, because we have about 7-8 minutes. Okay. So if there are any questions, you can answer all of them. Any more questions regarding SFO, MFO? I think I think you understood that if SFO, all the constraints are met, if all OAR goals are met, and that is usually what we prefer, SFO over MFO. But as Naufal mentioned, that for complex head and neck targets, as Daya mentioned, where OAR sparing is important, and there we probably will prefer MFO. Okay.
Inverse optimization?
Yes.
Yes.
It's inverse optimization.
That's a good question. SFO is an inverse optimization.
It's an inverse optimization.
Basic question. Once we do the optimization, compared to before optimization and after optimization, does the spot vary, or what does it actually vary? Does the energy vary, or is just the contribution of the dose varies? A little bit clarity on that.
Okay, so when we do the optimization is also when we do in Monte Carlo. It's going to take into account. See, if you do there are two things. One is called your optimization and the final dose calculations. So it is going to tackle all the beam path and final dose calculation. It's going to tackle all the things. If you put this as a pencil beam and the Monte Carlo, your distribution is going to change.
I think what Madam is trying to ask is, what exactly changes when you optimize? For example, in your photon, you know that the intensity changes. Here, what changes?
Okay. I think I'll just add some points over here. Optimizations means what we are doing is that we know that we are going to inject some proton and a position somewhere, right? So, and we also know that we are going to inject protons of different energies. Okay, so the question is where we are going to inject and what energy we are going to use, and how many numbers of protons has to be deposited at a particular point. That is what the optimizer is going to look. So during this optimization process, what the system is going to do is that, first of all, it is going to estimate the path length, the water equivalent length. Suppose if I put an imaginary beam, then and if I want to deposit certain amount of those at a particular depth, first of all, it is going to calculate the water equivalent length, water equivalent thickness of that particular part, and accordingly it will decide the energy. That is one part, and it will decide. Then second part is then how much dose you want to deposit at that particular location. And then after that, what the system is going to do is that, suppose if I'm taking the farthest point, then the dose at that point is going to be from that particular proton only. So how much proton has to be deposited, how many numbers of proton has to be deposited over there, that is what we call the mu per spot. And that is also going to be decided during this particular process. So this will be done for each and every point, okay? And these points have been defined during the time of optimization. So in the optimization process, we have something called spot spacing, how far we have to position the spot. And we also have some restriction that we should not inject more than this number of protons at a particular location. So all those has been defined into the treatment planning system, and accordingly, the optimizer will distribute the positions of the spots, and we also assign the number of mu per spot, which is the number of which corresponds to the number of protons in this process. And finally, once it is done, during the dose calculation, so it will produce the resultant dose distributions from this optimization.
Can I add to that?
So yeah, here you can see this is the spot map. So this is a target. So it starts from the distal part. So this is a spot map for this layer, and the intensity it's different. So it is something like layer by layer. It is so it is put the maximum energy. Each intensity is different. You can see the intensity of the spot is going to change, and it comes to next layer, next layer, next layer.
So this is when we are skimming through the tumor layer by layer. When he scrolls through, this one layer consists of these spots in the locations that are indicated, and the weight of each spot is measured by the size of those circles inside. So you can see in certain locations, so you can see the, just go back to the previous layer. Yeah, see that spot on the outside of the green line. So that has a very high weightage. So the isodoses that you see are a result of these spots.
Yeah. So the intensity is getting
1 minute. On the subsequent optimization, what the optimizer do, if you are not satisfied with this, in the subsequent optimizer, it will just adjust the weightage of each spot. Okay. Remain there. It will adjust the each spot. It will not add any spot after that. Okay.
Yeah, exactly. So it is depends on, suppose if you start with the same, you want the same spot map, or you want a different spot map. If you put a high constraints or different constraints, you can change your spot map and you can re-optimize.
So, Naufal, just one more thing.
Yeah.
Earlier you were saying that we always do the planning on the CTV, and putting the
robustness.
Before the robustness, before the optimization, you don't put in the PTV, but you go with the CTV with the uncertainties. You define the uncertainties system to plan for.
Yeah.
So in that scenario, like, do you actually have a oleum to quantify the dose deposition?
Yes.
Because the dose will be definitely spilling out of the CTV that you have, right?
Exactly, it should be. It should be. Because that's what I said. You have to produce a cloud. Okay. So different approaches is there. So one is called full PTV based approach. You combine PTV also plus CTV. That's called hybrid approach. Then CTV plus robustness, it's called full CTV based approach. Okay, so you can read our paper. Actually, it is published in JMP, which is, we mentioned all the 3 types of approaches in very clearly. And because, so it's again different. So most of the time we prefer to use the hybrid approach. You include PTV also in your optimize so that you ensure that your dose cloud is there. So this is, then you evaluate it. So I think the evaluation part is going to be done by my colleague Karthik. So he's going to explain whether it is,
Yeah, I think the evaluation part will answer your question of whether you can use the PTV to evaluate your plan and while optimizing on the CTV. So that is covered a little bit.
Okay, so
one more question, I think, from Dr. Uday.
What was called SFUD?
It is same.
So SFO is advancement of SFUD, is it?
Same. It's same.
It's the same. It is started from, it started from, if you see all the PSI papers, okay, they started with SFUD. Then if you see the American papers, they'll call it as SFO. So both are same.
Just the same
SFUD is same as SF4, and the MF4 is also called as a IMPT.